So moving on, our third speaker of the day, Joel Rhee is the Associate Professor of General Practice at the University of Wollongong and the current chair of the RACGP Specific Interest Cancer and Palliative Care Network and the GP Education Lead for the Advanced Project, which is an Australian government-funded program aimed at improving the capacity of general practice nurses and GPs in conducting care assessments. He's also the research lead for the New South Wales Health Translational Research Grant, funding a randomized controlled trial in ACP in Sydney. His presentation today is going to provide an overview of the ACP and its relevance to general practice and strategies for implementing ACP into routine consultations. Please welcome Joel Rhee.
Thanks very much. So the randomized control trial has really given us some really exciting results. So we've gotten our preliminary data from 6 months following the patients receiving intervention, and that's shown us that basically advanced care planning appears to reduce hospital admissions, unplanned hospital admissions by up to 20%, as well as reducing emergency department presentations. So it's obviously we're waiting for further results from that study, but Professor Gonski, who's I think speaking next, he's also involved in that. So it's something that we've been working closely with various local health districts. So maybe just to start off, we might talk about this scenario. So it's probably not an unusual scenario, but imagine if your loved one is lying in a hospital bed and they're too sick to be able to express their wishes. Not necessarily comatose or anything like that, but they've got serious illness, acute illness, and they're sort of not really themselves. And a doctor tells you that they can perform a procedure or operate or do something, but there are serious risks, and they're not even sure whether that's the best way to go forward. And they did mention that maybe it's better to let nature take its course. Now, if you haven't discussed anything like this with your loved one before, so the question is, what would be going through your mind? And so that's something which you can just reflect on, and we'll touch on this towards the end of this talk. Imagine a fairly similar situation. So this is scenario 2, where instead of the doctor sort of just, discussing the situation with you, the doctor actually shows you a piece of paper. You've never seen it before. Looks official, and it's definitely sort of written by your loved one, and it says, "I don't want to be resuscitated," very clearly. But your assumption in your discussion with your loved one that you had was that your loved one was full of energy, they didn't really have any serious illnesses, they wanted to live. That's your thought. You always assumed that was the case. Question is, how would you react to this? And we'll come back to that later as well. So just a few things which I think it'll be good for us to take away from this particular session. Just knowing a bit about the components of advanced care planning, and I think most people in this room would have probably be aware of some of those components or most of the components, but we'll go through them again. The benefits, the potential benefits of advanced care planning, as well as what are kind of resources that could be helpful for you in implementing advanced care planning. So either in your practice or in your aged care facility or other sort of settings that you come from. So what's advanced care planning? It's a question that, because a lot of people sort of interchangeably talk about advanced care planning, advanced care directive, but advanced care planning is actually a process of communication. So it's a little bit different to just thinking of that as a document or a directive. So it's where the patients, as well as their carers, families, loved ones, in conjunction ideally with health professionals, but we know that necessarily that doesn't occur, plan for a future situation where the patient no longer has decision-making capacity. So it's not always around end-of-life care. So it's around any situation where the person may lose their decision-making capacity. So obviously in the setting of dementia, people with Alzheimer's disease, those kind of things is highly relevant because we know most of those patients will lose their capacity at some point. It always involves having a discussion. That discussion could be 5 minutes, 10 minutes, could be 3 hours, could be over 3 years, like, you know, every few months for a few years. Or it could be one-off. It could be anything, really. But obviously when we, as health professionals, get involved in discussions, we have to document, otherwise it never happened. So it always involves record keeping from our end, but not necessarily formal documentation, although it's a good idea in many cases to actually create the formal documentation. So what we commonly think of as advanced care directive, which other people have mentioned as living wills. So in America, it sort of started off as living wills and then it sort of evolved into advanced care directives. So these are kind of documents that sort of lay out the patient's wishes, preferences. So a statement such as, I don't want to receive CPR. That's an example of an instructional advanced care directive. But advanced care directive can also involve appointing a formal substitute decision maker. So in New South Wales, we know them as enduring guardian. So we probably all know the difference between enduring guardian, who are responsible for health and making decisions around the living arrangements, that kind of thing, and then enduring power of attorney, who are responsible for financial decisions. So they're a little bit different in New South Wales, but in other states they use the term interchangeably, so they might call them enduring medical power of attorney, and that's a similar thing as enduring guardian, etc. So this figure sort of shows how advanced care directive or a formal document is only a small part of the overall scheme of things when it comes to making future decisions and having advanced care planning discussions. So why are we interested in advanced care planning? I think obviously it's increasingly recognised as an important component of end-of-life care, but also, as I mentioned before, caring for people who are getting older, people who may lose decision-making capacity in the future. GPs have a central role, but obviously it's not only GPs who need to do this. I think our study with the clinicians in hospital have shown obviously that hospitals have an important role, the outpatient clinics, the doctors working there, the nurses working there, the allied health working there, but also primary healthcare where GPs, practice nurses, and also the staff working in residential aged care homes, we all have shared role in this area. And the bottom line is this kind of thing will improve patient autonomy, but importantly, it will also help us in avoiding surprises, and it avoids us having difficult conversations later. Sometimes you may still have those difficult conversations, but it just makes things a little bit smoother. So there's several good reasons for doing it. In New South Wales, the situation is that we don't actually have specific statutory law in regards to advanced care planning, which is different to, say, Victoria. So Victoria fairly recently have, they just implemented a legislation on advanced care directives. So they got this very thorough and comprehensive framework on advanced care planning, which is enshrined in Victorian law. In New South Wales, we don't have such a thing, although we draw on 1987 Guardianship Act. Funny thing about Guardianship Act is that its main, I think when it was first introduced, its main sort of reason for introducing it was for protection and for allowing people with disabilities in particular to have some way for them to have a say in their decision making and for others to actually be able to make decisions on their behalf. So that it sort of comes from that sort of sphere, although it's really obviously taken on important role in palliative care and aged care as well. So we rely heavily on common law in New South Wales when it comes to advanced care planning. And everybody sort of talks about this case that occurred, I think 2008 or 9, where in Hunter, New England Area Health Service, There was a patient who was Jehovah's Witness faith, who presented to the hospital really unwell, and ended up having to need ICU admissions, dialysis, all those interventions. And then 2 weeks later, it came to the attention of the hospital clinicians that this patient actually may have this advanced care directive that they've written a year or 2 years before that. The funny thing about this advanced care directive was that it wasn't signed. There was no signature. It was handwritten, and they needed a witness to actually testify, no, this is the handwriting of that patient. And it was called a worksheet. So it wasn't really even like a formal document saying, I do not want CPR kind of thing. It's part of this larger group of documents, and it's a worksheet provided by, I think, Jehovah's Witness, that faith organization. But what basically happened was that the health service wanted clarity around what do we do with this? Like, do we have to follow this or not? But basically the decision made was that because it was written by the person and they had witness testifying to that effect, and it clearly stated the patient's wishes, and there were no reason to think that the patient didn't have capacity when he signed or when he wrote the form, it was regarded as legally binding advanced care directive, so even without signature. So this was the outcome of that law, and basically that sort of appears to be the barometer through which we approach advanced care directives and advanced care planning now in New South Wales, but also across rest of Australia as well. So that's just a bit of context into this whole situation with the law and advanced care planning. New South Wales Health also has produced guidelines on advanced care directives, and that's getting on, I think it's getting on sort of 14 years or so, 2005 or so they produced it. But it's not meant to be like it's not like a legislation, so it doesn't have those powers, but still it's being New South Wales Health and their recommendations, it's to be obviously followed if we can, or we should. And New South Wales Health has actually produced a new advanced care directive template, because until about 2 years ago, we didn't have an official form in this state, and even now we don't. But the New South Wales Health has decided, look, we can't have a situation where there's no even an example template for people to use, so therefore they created one. And they're not saying you've got to always use this template. You could use other templates if you like. But this one has been endorsed by New South Wales Ministry. It's gone through a fairly rigorous evaluation and piloting and other things. So Professor Gonski and our team, we were involved in helping the ministry with that sort of evaluation and piloting. So it's not compulsory, but highly recommended. So I'll give you a bit of a tour of that form. And I think in your packs, you should all have a copy. I think Lucy's been kind enough to put one in, and you can download additional copies off the internet, or you could order it, I think, from the ministry, but it costs them money to print, so I think they prefer you to download. Anyway, so it looks pretty snazzy kind of thing, and it contains the usual kind of things you'd expect from this document. So section where you put in the patient's details, and also the details of people who may make decisions for the patient. And then section 2 talks about personal values about dying. So I guess it's sort of heavily centered around end of life kind of, that spectrum of things. But it sort of gets the patients to talk about what kind of situations would be bearable, what kind of situations would be unbearable. So it sort of gives you a bit of an idea as to what they're thinking, what the quality of life is like, that kind of thing. And then section 3 becomes much more specific. So this is where the patient can actually document specific instructions when it comes to CPRs or other medical treatments. So example that's provided is artificial ventilation through a tube, or renal dialysis, or other life-prolonging treatments. But you can put in other things, like there's sections for other. And the feedback we got from when we were doing piloting of this was that it really depends on patients. So some patient, it might be a patient who's got a lot of vascular pathology in the lower limb and they're diabetic, and one of their things might be, what do they want in regards to amputation of their limb? Like, because if they really unwell and they're super septic and they can't make decision, they need some clarity on are they allowed to amputate or not, that kind of thing. So that might be really relevant for that patient. But for most of us, would we really want to put that sort of information on there? Maybe, maybe not. So you really need to tailor make it to each patient and their concerns. There's a section on specific requests for organs and tissue and body donation, so that's quite useful. But one thing to note about this is that it's tricky when it comes down to legal validity of this, because end of the day, often the hospital team would ask the person responsible about, they'll want to confirm it, and if the family really didn't want them to lift off organs, then they're probably not going to proceed. I mean, I guess they could take it to courts and other things, but would they really want to do that against families' wishes? They probably wouldn't. So this thing is a little bit less legally binding from that sense. But still, it gives the patient they can actually write down their wishes, and hopefully the family, everyone would be comforted by the fact that they agreed to that. And then finally, section 5 is about authorization and signature. The key thing here is that signature, you don't actually need health professional signature. So this is not a requirement in New South Wales. So even without it, it's still legally binding. However, it's still highly recommended, because if anyone was to challenge the document, or it also gives the person looking at this document later, hospital clinicians or other people, some reassurance that health professional was involved and they had some discussion about the choices that the patients made. And also these boxes, the first one is, I confirm that I had no reason to doubt the capacity of the person. So you could choose to tick that and sign as health professional. Or if you're a medical officer or medical practitioner, then you can actually confirm, I confirm that Mrs. blah blah or Mr. blah blah had capacity and was aware of the implication of the information in the Advanced Care Directive. So this one is a lot more, I confirm it. This one's more, I confirm that there's no reason to doubt the capacity. So which one you tick really, if you're a doctor, which one you tick is really dependent on your comfort level. I mean, I don't think as a doctor you have to necessarily tick this. You could just choose to tick that one. But if you sign it off, you don't have to sign. So that's not a legal requirement, but still it's a good idea for the patient to have this signature there. The witness signing it, once again, is not a legal requirement. So even without any of these signatures, it'd still be legally binding. But obviously, if there's going to be any disputes or any concerns that this might not reflect the patient's wishes, having all that information and having those signatures would help. So it's a good idea to get those signed off. So just a whirlwind tour us through the Advanced Care Directive form. So how do I start advanced care planning? So we looked at the form, we sort of found out a little bit about what it involves. I think there's two real ways in which we can do it in primary care. And first option is looking for patient queues. So this is much more opportunistic. This is during your routine consultation or routine encounter or routine when you're doing health assessments or whatever. Patient mentions something. And you probably would all have heard these comments being thrown by patients. And sometimes we sort of respond to that. Sometimes we, it's part of a conversation you're having, so you don't take too much note of that. But it sort of means that we can use these cues as a way to get into the conversation and introduce the whole topic. So a patient might be reflecting on their recent admission, and half the patients would be really grateful for their admission, the other half might be a bit traumatized, and then a few months later they might feel a bit better about going to hospital, but at least in the first few weeks they might say, look, I don't want to go back to hospital, that was nasty, I had to wait in emergency department for a couple of 24 hours and that was not good. Some patients might say, look, I don't want to ever go into nursing home, and it might be reflecting on their relative or their friend. They might say, look, over the weekend I saw my friend who's in a nursing home, and oh man, I can't, that's not a place that I ever want to go. If I end up going to that, to that level, I'd rather sort of, not be here rather than going to nursing home. A lot of people might talk about that. Some people might say, I don't want to have that operation. It might be a patient who comes in because they had some bleeding in the bowel, and then you're sort of recommending the patient, did you want to go see the specialist to have a colonoscopy? And they might say, look, what's the point? I don't want to have an operation for this. And then that might be a cue for you to obviously have discussion around that particular problem and that procedure, but also a general sort of discussion about their advanced care planning as well. So that's one option. Second option is to routinize advanced care planning in your practice. And this one's a bit more challenging because you obviously need to put in a lot more conscious effort into this, and it's not just yourself. You probably have to involve others in your practice and get everybody involved, and so it could involve a bit more work, but it could actually be an effective way to cover everyone who may require or may benefit from advanced care planning. So it might be as part of your 75 health assessment, over 75 health assessment, introducing this question. Do you have an advanced care directive, or have you appointed an enduring guardian? And a lot of patients might be, well, what is that? Like, they've never heard of it, so they might ask you, what is that? And then that might give you a bit of you might prepare a spiel to tell them about advanced care planning and then go from there. Another way to routinize it is to review your patient list. So you could actually do a search for patients who are over 75 years of age. You could even say, look, patients with certain conditions, and then you could narrow down the search, and then you could put in reminders or flags in those patients' files. Next time they come in, I'm going to ask them a question about this. So that's another way to systematically implement advanced care planning into your practice. Obviously, at this stage, and being a GP myself, one thing that alarm bell sort of keeps going, and do we have the time and resources? That's obviously the key thing, isn't it? And it's a recognized barrier, and obviously patients have barriers to getting advanced care planning, but also health professionals and GPs as well. Time, I think, is a real barrier, especially because there's no item numbers. There's no specific item numbers associated with advanced care planning, although Medicare has sort of they've confirmed that you can bill advanced care standard item numbers, including health assessments and chronic disease management, for advanced care planning as well. So that's all acceptable, but obviously not having that specific item is a barrier. And some of us might not be too comfortable. We don't want to talk about something like a patient got diagnosed with a neuron disease, so you might be thinking, I don't want to mention anything related to death to this patient, so you might feel uncomfortable, and that's all, I think, understandable. Now, we actually did some work around practice nurses. This few years ago, we had a registered nurse at UNSW who conducted this survey, and what it showed was that the practice nurses was very, very keen in getting involved in advanced care planning. So this first one is around initiation and conduct of advanced care planning should be the sole responsibility of doctors in practice. Like 3/4 said no, that's not right. The practice nurses should be involved in initiating and conducting advanced care planning discussions. 85%, 84% said yes, we should. So, and other things are very similar. Obviously, things like knowledge, there seem to be a bit of a barrier to that in relation to knowledge and other things. But I think our practice nurses appear to be very keen on getting involved. In terms of education and training needs, I think the nurses really wanted some training program, some opportunity to observe a session, and get some mentorship from an experienced nurse. So what we did was, we did that. And you may have heard of Advanced Project. You may or may not have. I brought some flyers for you to look at. But that's the website you can go to, theadvancedproject.com.au. And we developed a bunch of resources and online learning activities. And this is designed for general practice nurses and GPs in implementing advanced care planning in your practice. So it's got everything that you really need to implement. We try to make it really user-friendly and relevant to general practice, because there were few of us GPs involved, and also practice nurses involved in designing this whole thing. And that's led by Josephine Clayton, who's a palliative care physician. So that's something you can have a look at. Now, which patients are suitable for advanced care planning? So I think this is a fairly common question. And ultimately, a lot of people say, look, any adults are suitable, and there's no real, you don't have to have a cutoff. Anyone, because anyone can get hit by a bus. Yes, absolutely right. However, I think a certain group of people are probably more likely to think and reflect on their what may happen if they lose capacity or if they were close to dying. And I think that's mostly people who are older. So for instance, 75 years of age, or who may have a new diagnosis like dementia, or who've been diagnosed with some life-limiting conditions. I think that's probably going to be more relevant for these people. It's going to be much more challenging to grab a 22-year-old triathlete who just completed surfing advanced care planning. They might be thinking, are you holding back some information from me? Do I have something? So I think this is more relevant. And sometimes the surprise question helps. So the surprise question is, would I be surprised if this patient was to die in the next 12 months? And if the answer is no, you wouldn't be surprised, then that patient may benefit from advanced care planning. If you want something a bit more systematic and a bit more comprehensive, then you can actually use something like a SPICT, and that's Supportive and Palliative Care Indicators tool, developed in UK, but used all over the world now. And you've got different versions of this, including ones for Australia and other countries, but also ones designed for low-income countries, and also ones that can be used by non-health professionals, so lay people as well. So different versions, because some of these things are pretty technical. So that's another tool that you could use to work out, is this patient suitable for advanced care planning? Now, there are basically two things involved in advanced care planning. The first thing is, who's going to make decisions for the patient if they're unable to? So we talked about enduring guardianship, so that's one aspect of it. And then how will they make decisions? And that's the instructional advanced care directive or conversation around that. So I think what I'll do is I'll probably touch a little bit on the who's going to make decisions for me, that aspect of it, because we're running out of time, I think. And to do that, we need to talk about capacity, so decision-making capacity. Now, decision-making capacity, I think I've attended a few talks given by various specialists on this, and they could really, talks can be 2 hours, 3 hours longer. So this is potentially quite complicated topic. So it's pretty hard for me to do it justice in, 3 minutes. But I probably would just want to leave you with a few principles, and this is a really good resource that you could look into, Capacity Toolkit, and that's the website link. You'll notice that it's mainly legalese. It's a legal sort of thing. But the first principle is decision-making capacity is all about a person has capacity to make a decision if they can understand the facts and choices involved, so they can understand. Second one's weigh up the consequences and understand how the consequences affect them. So the second one's more about processing. And the third one is communicating. So they need to be able to take in the information, they need to process it, and they need to be able to communicate it back. That's the key things in capacity. So what's interesting about that is it's nothing to do with mini-mental state examination scores. Although obviously someone who scores really low in MMSE probably won't be able to do any of that. So that's obviously something to keep in mind. But low MMSE by itself doesn't mean they've got no capacity. Second principle is the presumption that all adults have decision-making capacity. So this one says, is it innocent until proven guilty, or is it guilty until proven innocent? So in this sense, they are presumed to have decision-making capacity until proven otherwise, basically. But that doesn't mean that just because you haven't proven someone doesn't have decision-making capacity, you should not protect them. Because sometimes the patient is at imminent risk of harm, and in that situation, you've got strong suspicion they may not have capacity, even though you've never proven it, you haven't quite proven it. In that situation, you may need to do something about that. So I think it's we need to approach that with caution, but still, all adults have decision-making capacity until proven otherwise. Third principle is decision-making capacity can vary, so it does depend on type of decision. So whether they can decide on receiving a very high-risk surgery for something versus what choice of custard they'll get for lunch. Like, that'll be very different. So they might have capacity for one thing but not the other, so you can't lump everything into one basket. Also timing. So sometimes patients are acutely unwell and they may not have capacity, but in a stable environment, they may have capacity. And physical environment, and also it can be lost and regained. So it's something which is not static but dynamic. And obviously, in dementia, in the early stages, it's going to be probably a bit up and down until, obviously, when it progresses, then when they completely lose most decision-making capacity. The fourth principle is we need to really focus on their ability to make the decision, not on the decision itself. So just because we don't agree with what they say doesn't mean they've got no capacity. However, if the decision they're making is so out of character or so unusual or potentially completely harmful for the patient, in that case, it may mean that you have to be really careful in assessing their capacity. So it may flag the need to assess their capacity, but decision itself doesn't mean they've got no capacity. So what does this all mean? This is my own approach. So whether you want to take that or not take that, completely up to you. But this is just my approach, and I wanted to share this with you. So my own approach is, if something is clear, so if it is clearly in or out, I'm quite happy to call that. So if someone clearly has decision-making capacity. So yesterday I saw a 93-year-old patient who's sharper than me. Like, memory is so good and so sharp. In that case, clearly she's got capacity. I mean, I'm very happy to sign, that person's advanced care directive form. Another person with advanced dementia in high care, so this person's completely out. I mean, you can see it. I'm very happy to say they got no capacity and they can't write an advanced care directive because they don't have capacity. Sometimes it's a shade of grey, so it's not black or white, but shade of grey. So this person, is that cricket bat grounded? Maybe, maybe not. We don't know. In that case, I send it up to the third umpire. So someone like Professor Gonski, someone like old age psychiatrist. Example might be someone with mild to moderate dementia. So you probably think they were some capacity at least. But something about them makes me think, are they really getting everything? So in that case, I might say, look, it's a really important decision here. In that case, maybe I want to send them up to the third umpire to get what they think. So that's what I tend to do. But also, I always make sure when it comes to advanced care directive, I'll actually get them to demonstrate their capacity to me. So they need to be able to tell me the nature of their decision. When is it meant to apply? When does it not apply? So for instance, when does it apply? It applies when they lose decision-making capacity. So even if they sign everything, they could change their mind anytime until they lose their capacity. When does it not apply? The consequences of following the document. So all of these things, I get them to say it back to me or communicate that back to me. And if I'm satisfied that they completely understand it, then I'd be happy to endorse that. Or I'm happy to advise a patient or their carer, that they don't have capacity either. But in the middle, I refer to someone else. The other thing is, sometimes you get this request from a solicitor or someone saying it involves a will or financial matters and there's some conflict and they want you to write something about whether they had capacity or not. In that case, I try to stay out of that because I feel, well, okay, this is going to get complicated. And when it comes to these kind of decisions, I tend to also refer on rather than taking that on myself. So that's just my own practice. So just to re-emphasise the no legal requirement for a health professional to sign off advanced care directives in New South Wales. And maybe I'll just finish off today by just going through this slide and we'll finish off. So let's say a person has lost decision-making capacity and they don't have advanced care directive. In that case, when you're making decisions as health professionals, you're meant to follow the hierarchy of decision-making. So probably most people know that. But sometimes we think of, let's ask the family or next of kin. But as far as the Guardianship Act goes, there's no such thing. There's no next of kin. So what you're meant to do is you're meant to go down this list and you're meant to find someone who's the highest person on that list and get them to provide consent or that kind of thing. So first person is enduring guardian or a guardian appointed by the Guardianship Tribunal, or they changed their name now. If there's no one, then it's the spouse, including de facto, and that includes same-sex couples. But someone who's got a continuing and close relationship. So someone who is still married but hate each other and haven't seen each other for 5 years doesn't count. So it's de facto or same-sex couple. And then it'll be a person responsible who's, the first person off the rank is unpaid carer. So they can still receive carer's pension, that's okay, but you can't be paid. So you can't be like a worker, like can't be a GP looking after the patient because we're paid for that. And then after that, it's close family members or friends. And funny thing is, there's no definition of like what that means apart from the fact that they've got a close personal relationship with you and you care about their well-being, that kind of thing. In other states like Victoria, they actually specify the order. So like family members, it actually says the eldest, like eldest adult children trumps the youngest. But in New South Wales, no such thing. And I think in South Australia, it's the family goes before, like there's an order to that as well. But in New South Wales, there's no order. This is all treated the same, but carer, unpaid carer, tops that. So we're meant to follow this hierarchy and find the highest person on this thing to get consent off from. Now, obviously, the problem is that following this thing is dependent on individual health professionals. So I'll probably try my best to find this, but what's the guarantee that I'll be able to find someone that the patient really wanted for me to find? Like if I'm trying to find a family member, I could end up choosing the second son, but the patient in their head wanted the third son. What's the guarantee that's going to work out that way? There's no guarantee. So what we would recommend is that if patient wants someone strongly, they really ought to appoint them as enduring guardian while they still have capacity. That way they're assured that that's the person who's going to be making the decision. So I probably finish there. Thanks very much for your time. Probably no time for questions.